Yeah, my head is shining.
That's
I got this big.
okay.
Okay, hey everybody. I'm just remarking on my shining forehead. It's okay. Forehead the size of Montana. I like to think there's like a large brain underneath all that, but we'll see. I don't know which camera to look at here.
This one.
This one? Okay.
The following program has been paid for by Dr. Stephen Petteruti. It is for entertainment and basic informational purposes only and is solely responsible for its content. It does not reflect the views of Cumulus Media, WPRO, its management, or its staff. News Talk 630 and 99.7 FM, WPRO presents Intellectual Medicine with Dr. Petteruti. Join Dr. Petteruti as he guides people towards living the 120 lifespan while retaining youth. He'll apply logic, reason, and scientific evidence to address conditions that drain people of their joy and vitality while protecting people from the harmful aspects.
It's like to be on a duck boat in 70-mile-an-hour winds. That's awful. Good morning, everybody. It's Dr. Petteruti. This is Intellectual Medicine. I'm here with Shannon, along with Tyler behind the glass, on another beautiful Saturday morning in southern New England. It just doesn't get better than this, people. This is why we live here. This is why we call it home. That's right. We get about 8 days like this per year, so go out there and enjoy them. Today, folks, we're going to be talking about a range of issues. We need to reflect upon the strike and the effect it can have on the health, the life and the death of Rhode Islanders and what's gone wrong. This is emblematic of the brokenness of the corporate system of medicine that is completely degraded, and there's a void of leadership and a void of accountability to the patient. And that's to you, dear listener. You are the patient. We need to talk about, Shannon, we need to talk about the nature of proof, the nature of evidence, and how things are moved forward. In the world of medicine, there is a comfort in conformity. Everybody does things like everybody else because it gives them comfort. At intellectual medicine, we break that mold, and we break it thoughtfully and purposefully in the pursuit of better outcomes to address our patients' concerns. Number one, the healthy that don't want to age. There is science supporting pathways of care that can delay the signs and symptoms of aging. Those pathways of care, those treatments, the scientific evidence of that benefit is stifled in its ability to get to patients. I don't understand this at all. We know that aging itself, aging is the leading cause of disease across the board. We know that the lifespan has been expanding dramatically over the years. Why is it then that anybody would attempt to hobble the pursuit of therapies to delay aging itself? Well, we don't. And you know, folks, you are voting with your feet, you're voting with your radio dial, you're voting with your interest and your resonance with intellectual medicine. We thank you for that. We thank you for being part of this movement. This will not improve from the top down, people. You will not get healthier by going to see your doctor. You will not get healthier by going to the hospital. You will not get healthier by following the guidelines issued from the summit of orthodoxy. You must take it upon yourself. Healthy skepticism combined with intellectual pursuit will lead you to a better place if you're interested, right? This is optional. You know, I like to tell the story of this the patient who had a heart attack, and he came home and his son was telling me, you know, I was so annoyed. There was my father after his heart attack smoking a cigar and eating a steak. I said, Dad, what are you doing? He said, he's doing what he chooses to. He is telling you his philosophy is not one of maximizing longevity and health in the moment, but enjoying a cigar and a steak. Now, I choose not to pursue the cigar steak philosophy, if you will. I like the idea of living longer, living healthier, but it's my prerogative. It's your prerogative. And without the freedom of choice, well, you become a victim of limitations. I know I'm getting a little tangential, but we got to bring it back into the focus, Shannon, because there is scientific validity behind everything that we do at intellectual medicine. But the notion of absolute proof is absurd. Think about it from this perspective. if there is no remedy for a condition, it begs for an innovative approach. Let's take as an example chronic fatigue syndrome. Okay. What's the treatment, Shannon, for chronic fatigue syndrome? There's no cure.
There's no cure. You're tired. That's what you have.
You have chronic fatigue syndrome. Okay. There, folks, is a wide open field for innovation. And Dr. Michael Souza and I, through intellectual medicine, along with Shannon, we pursue avenues to remedy this based upon basic science. We know mitochondria are power packs of the body, so we address things that are restorative to mitochondrial health. Is it proof positive? No. However, if we are denied the freedom to be innovative, there will never be any change in the status quo. If the only thing doctors are allowed to do is that which has previously been done, by extension of logic, nothing new will ever happen. Now, this is an absurdist premise. I think you'll agree with me that it deprives the patient and the doctor of intellectual pursuit. That's what we're after, intellectual pursuit. So we're going to talk today about the role of vitamin C. Where is the evidence supporting its merit with regard to infections and cancer? We're going to talk about the distant metastatic risk of cancer itself, breast cancer in particular. You get to that 5-year mark, you get a thumbs up. What does it mean? Are you really cured? Does cancer ever truly go away? There's this post-cancer treatment risk that perseverates. But Shannon, I mean, you started your career out as a nurse, as an RN. You still are an RN. You're now a nurse practitioner. Tell me your thoughts. These nurses are going on strike at Rhode Island Hospital. That's gotta hurt them. It's got to be hard to walk away from patients.
I think it is. I think the harder part is living with what they're living with and the care that they can't give to their patients because they just don't have the time, and they're scared because people can get hurt.
So here we've got a circumstance. Over 2,000 nurses are going on strike, folks. You need to dial this in. And they're going to replace them. This kills me, right? They're going to airdrop 2,000 plus nurses into a complex medical entity known as Rhode Island Hospital, and everything's going to be fine. It'll go along like nothing's different.
I'd be running from that hospital right now.
Are you kidding me? We're not talking, folks, about people pushing brooms. We're talking about nurses. How long did it take us to hire one nurse at Intellectual Medicine?
Oh, months.
Months.
It's just the training.
Months, but you push a button and presto changeo, up spring 2,400 nurses that was sitting. What do you pull into like Home Depot with a pickup truck and say, hey, any nurses, hop in the back?
No, and I mean they could be excellent nurses, but it
Right.
doesn't matter. There's a learning curve, and it takes months to learn
Right.
what goes on there.
Just to learn how to turn on the computer.
Right.
You know, and you think about the speed at which things occur. I was thinking about this the other day. You know, Tanya and I, we do procedures together. Molly and I do them together. And boy, I'll tell you, when you get it down and you're doing a procedure, it gets slick. And you miss that. The nuance, the detail in the emergency room, in the operating room, on the floors. Where's the medicine? There's a code. Where's the cart? Is it delayed 30 seconds? Oh, but don't worry. We're going to have monitors there. Great. That's what we need, right? More bureaucrats with clipboards are going to fix everything. This is ridiculous. Rhode Island Hospital should be ashamed of themselves. This is a failure of leadership.
And it's not about they want more money, they want more time off. No, they are saying we need help.
Are those some of the
Patient
issues?
safety.
Look,
Yeah.
I don't know the details of the issues, but as a Rhode Islander, I know the outcome. We trust this hospital and these people with our health care. You know, this is a bad week to get a heart attack. You best go to Intellectual Medicine and get your drips and stay healthy. You do not want to get sick this week. Absolutely. Oh, that's fine. You go to another hospital. Yeah, good luck with that one, right?
We packed.
It'd be jammed. You're going to have patients in the parking lot in gurneys. Where's the leadership? This is an acute and present danger to every Rhode Islander. Where's the leadership? Where's the governor? Where's the Department of Health? How are these people allowed to let this occur? It boggles my mind. Are they going to shut the hospital down? Are they going to strip it to its key and essential elements? There should be nothing elective happening at this hospital until this issue is settled. Anyhow, but we do need to take a break. And when we come back, we're going to tell you about vitamin C, about the evidence for infection, and about why not to use antibiotics in most cases. along with what else? Oh, vitamin C and skin cancer. So we'll be right back. This is Dr. Pederuti at Intellectual Medicine. See you in a minute.
Oh my gosh. So
Yeah.
Paul writes, "Hey Doc and Shannon, greeting from a hot and oppressive Texas. The heat index was 114.
Wow.
I think it's like 62 here right now, Paul.
116 is a heat index. That's something you got to adapt to.
Wow. Well,
Yeah.
that's like it being like what, -10 here in the winter, right?
Well, yeah, the difference is you just turn the heat on.
I'm saying. I mean,
Because down there you turn on the air conditioner. I get it. Yeah,
you
yeah.
have to run to your car.
Yeah.
Well, imagine getting that sucker.
116, but it's a dry heat.
Dry heat.
I don't know. No, down in Texas, I think it's pretty humid, isn't it?
Oh, he'll be up in August. We'll stop in.
Oh man,
Oh,
looking forward to it.
Paul.
Wow.
Oh.
Yeah, I don't know. It's just not right. This is the inevitable consequence, people, of the corporatization of medicine, where you've got a disconnect between the leadership of the hospitals and the rank and file workers down the line. Now, on the other hand, I think a 3-day, now they're planning, Shannon, it's a 3-day strike. So they're going to strike for 3 days and then go back to work. How is this logical?
I think their hands are tied. This has been going on. This isn't new.
Yeah.
I've been saying they keep cutting, they keep cutting, they keep cutting. When really, I've talked to nurses that work there,
Yeah.
and they're really concerned. Mistakes happen all the time. They don't have to happen because they have 6 patients, 9 patients. You can't take care of that many patients.
Yeah.
That's all they're saying. That's what they want.
There are too many assistants to the vice president,
And you can't have CNAs taking over nursing duties, and that's what they're saying. We'll have the CNA do it. They're not licensed. They can't do that stuff. They can't monitor patients.
Yeah. There's a I don't know, qualitative difference, right, between a nurse and a CNA. A nurse has spent years and years and years in higher education. A CNA did a 3-month course. You can't constantly extend your resources, your intellectual and physical resources, and expect no compromise in outcome and patient care. And the ones that see that are the nurses. And they see it before it shows up statistically. And that's gut-wrenching when you are responsible for somebody's life and you don't feel like you're getting full support. You're where the rubber meets the road. Anyhow, what do you want to talk about? You want to talk about the shingles and vitamin C?
Sure.
Breast cancer? Yeah. Okay. For the valsartan recall, we need to talk about too. What are they doing over in China? How do you get a carcinogen in your drug? How? 1 minute. We got to talk about Suboxone as well. Doesn't somebody have the power to just step in and take over and nationalize the hospital and command everybody back to work?
No. The teachers, right? I don't know. There should be a national patient ratio. You're in ICU, it's 1-to-1. You're in this, it's in 3-to-1. Whatever it is.
Yeah.
Look, we have the study saying that X amount of patients, everything is fine. You add 1, you add 2, bad things happen.
Yeah, this is terrible, and they can't accommodate the nurses' demands, but they can write a check overnight for $10 million for scab labor. How does this? And then they turn to the nurse and say that $10 million is coming out of your money. That's mean. That's just not good negotiating.
Now back to Intellectual Medicine with Dr. Pederuti. Call in now at 438-WPRO or 1-800-321-WPRO.
Hey everybody, we are back. It's Dr. Pederuti along with Shannon. I cooled off just a little bit, but I got to. So here is the leadership at Rhode Island Hospital. Cutting. We can't, Shannon was just talking about you were there at the hospital, and the nurses' duties are being extended, and they're forcing them to cover more patients, to do more documentation, and they keep making them, manage nursing assistants. So once upon a time, you'd go to a hospital and the person at your bedside was a nurse. And then they invented new titles. One of them is a CNA, certified nursing assistant. These are good people with good hearts, and they do have a role. However, they're being forced into more and more duties, in my view, because their salaries are low. So you can hire CNAs, and you can extend the nurse and say, you know what, nurse, instead of being in charge of 4 patients, we're going to make you in charge of 12, but we're going to give you a CNA. You know, in medicine, we used to have a saying, show me the resident that only triples my work and I'll kiss his feet. Sometimes you're better off doing things on your own.
Part of the CNA though, when they're sitting there and the stuff they do is really like the bathing and I don't know. As a nurse, if you were doing that for your patients, it's a great time to assess them and talk to them. So now you're charting and you're giving meds and you're in there for 2 seconds, but you're not actually sitting there with them.
Time.
Mm-hmm.
There's no replacement. And then, we'll move off this topic, folks, but one last thought. The negotiators and your eminent leadership at Rhode Island Hospital stonewalling the nurses and not finding a way to get to common ground, but they can drop a $10 million check overnight to some helicopter nurses that are going to drop in from all over the planet. How does that equate, and how does that build good faith? And then they turn to the nurse and say, that $10 million has come out of your hide. That's horrible negotiating strategy. That's provocative and confrontational. I'm mad, and I'm not even a nurse there. Well, I'm a patient in Rhode Island. Right. Suppose I get a heart attack. Do not take me to Rhode Island Hospital, Shannon.
Going there, don't worry.
You drive me. I don't care. You drive me to Montana. I don't care. I'm going to Mass freaking General. That's where you're taking me. That's right. I better not get a heart attack. If I get a heart attack this week, it's not natural causes. You want that investigated. I want a full autopsy on me because somebody poisoned me. Where are those Russians? All right. Anyhow, we talked a moment ago about proof, evidence, and progress. And some areas beg for innovation. Certainly one of those areas is obesity treatment. We've been advocating for our intellectual medicine advanced approach that Dr. Souza uses at East Bay. How do people find us? They go to our website.
They can go to our website. Yep.
How do you get there?
im-120.com.
The letter I, the letter M, the number 120.
Yeah,
oh, I get it. As in 120-year lifespan.
Get it. Yeah.
That's pretty awesome.
So you can just Google intellectual medicine.
That'll work too.
Google you.
By the way, Tyler, our listeners, if they're on 630, if you can update them on the antenna thing, please. Very cool. So as we're on the air, Tyler, we're on both FM and AM. Is that right? That's so cool. I didn't know we're on both. And online. That's awesome. So obesity epidemic, it is an area of, how to put this best, Shannon? It's overlooked by Orthodox medicine. Shall we be kind and say that?
Be kind.
Okay, thank you. Mm-hmm. If anybody has ever told you to diet and exercise as a means of losing significant weight, they are manifesting their ignorance on the topic. This is not a failure of intellect nor character. It is a complex neurotransmitter and biochemical and hormonal issue that requires the trilateral treatment approach at intellectual medicine to have durable success. Permanent nutritional change, not a diet. Sequential polypharmacy. You must use medications in most cases in a balanced manner to achieve durable success. And then the thoughtful application of nutraceuticals and supplements. Now, why is all this relevant? Well, in the United States from 2000 to 2016, the rate of liver cancer shot up 43%. It has increased from 9th to 6th. And one of the major causes is obesity and fatty liver. We need an innovative approach. We can no longer sit idly by. There's a call to arms, and intellectual medicine is leading that way. This is overlooked by mainstream medicine. Another area that we require innovation. And you know what, Shannon? We don't even need that much innovation. We need to apply what we know. The New England Journal of Medicine had a beautiful summary of the treatment of opioid addiction. We were talking about this on the way up here. And we both, Shannon and I, both remember a time when the treatment for pain was opioids and the treatment for inadequate pain control was more opioids. You remember that era?
Oh, I do. Very
Yep.
well.
And the drug companies were pumping out oxycodone, and they were paying experts. My hands are in there making a little fake quote thing. Experts. An expert, by their definition, somebody took a fat check to talk at a dinner. Hey, you know what? I was swept up in this, Shan. We were all swept up in it.
I was saying we had standing orders for opioids. Patients said they were in pain. You had to believe them.
Right.
They knew there were orders for whatever they wanted, and we had to give it to them.
Right.
No questions.
No questions. Because if you question them, then you were being confrontational.
Right. It's a fifth vital sign.
Yeah.
Right. What year did that come out in?
I'm thinking about 15 years ago when all this started to happen, and we thought, boy, in primary care, we're like, we want to help our patients. And you look at somebody, when you see the face of pain, your empathy moves you to try to remedy it. And we were told that there is no upper level of titration for opioids. That if they're in pain, you give them more until the pain goes away. Constantly titrating upward. We didn't know it, but we were priming the pump of an addictive epidemic that we are now harvesting the fruit of, if you will, or the consequence of. Fortunately, changes are underway. And some of those changes are thoughtfully being led by our Department of Health. Actually, you got to give them credit for the things that they've done well, and that's one of them is limiting initial prescriptions and some other attempts. Now, there is no proof of outcome, but it's an extension of logic that if we can limit the initiation of the drug, we can mitigate the subsequent addictive rates. But what if you're already addicted? Well, the New England Journal summarized it beautifully. The Suboxone treatment is the king of therapies, one of the main means of preventing relapse. Now, Shannon, you've studied this. You're now certified in Suboxone therapy, as is Dr. Michael Souza. And we have established at Intellectual Medicine the Executive Suboxone Program, intended for those that want to step out of the muddle of the Suboxone clinic environment if that does not suit your need. And Suboxone clinics are totally appropriate and service many patients. They're just not for everyone. And they do not extend their care to address some of the side effects of Suboxone therapy, like obesity, chronic fatigue, and sexual dysfunction that can occur. But that study showed that the one therapy was Suboxone, that the 30-day treatment programs actually increase the risk of death because people come out of those off their drug, but not off the addictive impulse. What's the relapse rate coming out of those? It's pretty, isn't it over 90%?
97%.
For real.
97%.
So the 30-day inpatient, this summarizes, we don't need to continually throw more money at this, people. We need to capture what's there. Well, we need to talk a little bit more about that and about the vitamin C, the study showing its benefit with skin cancer, and our approach to secondary prevention at Intellectual Medicine. We've been talking about this throughout the course of our existence because we think it's a desperate need. If you've ever had cancer, what do you do next? You can't stay on chemo forever. And we'll talk about all these issues. Hey, Ty, how am I doing? We can cut to Doug Lizette here with the news. We've got that coming up from the Revolution Southwest News Center. It's our own Doug Lizette with the news. Good morning, Doug.
Two questions. I want to know what's the difference, similarities and difference between methadone and Suboxone.
The difference is more administrative than it is medical. Both methadone and Suboxone are forms of opioids that are non-euphoric, so they tend not to make people get the buzz that reinforces perpetual use. When methadone came to market, they were concerned, the government and others, that it would be too widely dispersed if it were just prescribed by regular docs. So you had to become a methadone clinic where you would administer it on a daily basis. Methadone is an interesting drug. The dose of it has to be watched closely because it takes about 3 days for that to achieve its plateau. So methadone clinics sprang up. Problem, a lot of people don't like going there. And the methadone clinics were, in some cases, perceived as a mill generating more profit than therapeutic benefit. The other problem is access. Methadone clinics tend to be in poor neighborhoods. A lot of people don't want to drive there and go to the clinic and stand in line and get their daily cup of methadone. So Suboxone came along, and Suboxone was supposed to be mainstreamed. That means that family doctors and primary care could prescribe it in their office. And the idea was that addiction is so widespread, we don't want to stigmatize it by forcing people into clinics. We're just going to blend it in. Problem. They required that you take a special course to prescribe it. Now, bear in mind, you don't need any special course to prescribe Percocet, right? You could do that the day you graduate nurse practitioner or medical school. So this course is a barrier to entry. So most docs are choosing not to bother. The other problem, the DEA supervises, and not supervises, but they monitor the centers or the doctors that are prescribing Suboxone. So by virtue of your desire to help in treating the epidemic of opioid use, you get the pleasure of a knock on the door from the DEA with their badges, bust in your office whenever they want, unannounced, to randomly screen your charts. Most doctors don't like that. I've heard stories of doctors that are prescribing Suboxone having the DEA come in, clear out their waiting room, shut the office down for the entire day so they can plow through their charts. So doctors have not rushed to acquire the skill to, or I should say the privilege to prescribe Suboxone. And you can see why. So ironically, what was meant to be a mainstream treatment has turned into Suboxone clinics. I've prescribed both drugs. They both are extraordinarily safe. They both can be. Actually, I don't think I prescribe Suboxone.
No, or you can't prescribe methadone.
I'm certified for it.
You are.
I just chose not to do
You
it.
can't prescribe methadone though.
You can only prescribe it for chronic pain.
Not methadone.
Yes. Yes. No, you're wrong. I've done it for 20 years. Now, when you prescribe methadone as a primary care doctor, you must write on the prescription for chronic pain. Methadone. Methadone can be used for chronic pain. Shannon's looking at me sideways. I know I'm right on this.
You can do Suboxone though too.
You can do methadone for chronic pain. Methadone is super cheap. It's 10 cents a pill. And I've used it for chronic pain in some cases where people were poor, couldn't afford anything else. Thanks for asking that question. I think what it turns down to, we should talk about the brain changes. Just erase somebody?
No, I just changed the comments. I don't know how I did that. I don't know if that screws them up. Terry would like to know, is there a drip for weight loss?
Is there a drip for weight loss? There is no drip that will melt fat off of you. There are drips, however, that can support your micronutrients as you're going through a weight loss cycle. One of the challenges with people of obesity is they tend to be micronutrient deficient. To a person, everybody we've tested has been deficient in vitamin D and often inadequate levels of vitamin B12. We should talk about that case, Shan, the B12 case. A lot of times obesity creates an inflammatory state that irritates the gut. An inflamed gut doesn't absorb micronutrients as well. And it can lead to some of the secondary symptoms of fatigue, lethargy, bloating. So unfortunately, there's not a drip that you can get that will just melt away 30 pounds. But in some cases, we do use it for support. It's hard. I wish there was something simple. There we go. Drugs. So we got to talk about
do the cancer. See, with the skin.
Skin cancer.
I think that's absolutely fascinating.
Okay. Yeah.
Hair loss? I know what you're thinking. Should I shave my head? Comb it over? Wear a hat? Just stop. This isn't 1970. Keep your hair and your confidence because Bosley, America's #1 hair restoration expert, can give you.
I could use a couple more follicles.
Right.
Thinking. We should do. They should do hair transplants. They don't have that, right?
Hair transplants?
Yeah. You get some 20-year-old with a bushy head and you just transplant it over.
Your body would kill it.
There's got to be a way to clone hair follicles.
Right? Petri dishes sitting around wanting to.
It seems easy to do. We'd ask some of our expert colleagues about that.
free.
Not good.
How awesome your hair can look with an absolutely free 10-second gift
Right.
card for $250 off. Text GROW to 85850. Ask about the Bosley Guarantee. GROW to 85850. Now back to Intellectual Medicine with Dr. Pederuti. Call in now at 438-WPRO or 1-800-321-WPRO.
So there I was. Well, welcome back, everybody. It's Dr. Pederuti along with Shannon on WPRO, your intellectual voice of Southern New England. Ty, I can do that, right? I can add a little word to our phrase, right? Yeah, it's intellectual. Your intellectual voice of Southern New England, right? Our listeners are among the most educated, most intellectually curious. So when I tell you that it was 12 years ago, Shannon, we began this journey of intellectual medicine, about 10, 12 years.
I'd say 10.
All of that.
10's a long time.
And I was skeptical when I first started hearing and reading about intravenous vitamin C and its power to have an effect on everything from bacterial infection to Lyme disease to cancer. It seemed to me a little bit over the top. And I started researching it. And I have never stopped. And the more I look at this issue, the more we see the evidence build. And ironically, the more we see the opposition mount. The opposition has a common denominator in most cases. They are orthodox in their approach, petrified in their thinking, lacking in creativity, lacking in intellectual curiosity, and devoid of really balanced and thoughtful pursuit of the evidence. The best you could say is they're reactively negative. And that's not always a bad thing. It's like, prove it to me. Okay, so here's a study, Shannon, the one on vitamin C. I thought this was absolutely fascinating.
Me too.
They took high-dose vitamin C, created a compound out of it, and applied it to basal cell skin cancers. And guess what, folks? The skin cancers melted away in the majority of cases. Now, this is not absolute proof, but the clinical study, well, actually it is.
It is.
I mean, there were photographs.
And it was quickly. It's not like it took weeks and months.
They treated them in some cases for several weeks.
Oh, no, I know. But
yeah, the benefits started early.
Yes.
So instead of going in and having the cancer surgically removed with scar tissue left behind, they simply put on a high potency compound of vitamin C, occluded it, covered it, did that 3 times a day, 2 to 3 times a day, and the skin cancers melted away. How fabulous. How interesting. It turns out that vitamin C is toxic to cancer cells.
Shocking. We've only known that for like 40 years.
And when you apply it to topical skin cancers, the skin cancer can go away. Well, what's the downside of using this approach? Let me think, Shannon. Okay, I'm having trouble coming up with a reason not to try it. The worst thing that happens is you're going to delay an intervention. And an inappropriate urgency to treat an indolent disease can lead you to make mistakes. So when you have things like skin cancer, if you want to try a novel approach like high-dose vitamin C topically, this is what we're here for. We are your hub of innovation. Slowly moving toward a treatment. Now, Shannon, how about the case that you saw? Follow up. We're talking about the need to be deliberate in the face of medical information that is not urgently life-threatening. And tell them about the patient you saw in follow-up recently that I saw.
I haven't seen her. She started with us a couple years ago, and I haven't seen her, I would probably say 18 months. So she came in for a weight follow-up, and we were chatting, and we were talking about what supplements she was taking, and we were talking about B12. She said, years ago, she came to us, and they were actually working her up for MS because she was having something was going on with her eyes and these symptoms, and she had told you they were going to do an MRI with contrast. And you said, whoa, hold on. We just got your blood work back. You're really low in B12. Let's try, kind of replacing some of these vitamins and see what happens. And she said within 48 hours after starting just B12, her symptoms were gone.
Yeah. So that is a fantastic story, and it's not isolated. And the take-home message, folks, is if you're given a diagnosis of a disease state that is slow-moving, non-life-threatening, and the advice is to launch into aggressive imaging and treatment, my advice is to pause, think, and seek alternatives before you jump on that train. Now, let's suppose for a moment, Shannon, that patient had gone through a cycle of vitamin C therapy and the symptoms progressed. You haven't lost anything. You can still go through the assessment for MS. There is no strong evidence that starting treatment early will make a difference in outcome. Another circumstance is similar. A patient I saw recently was evaluated by his pediatrician because he wasn't gaining weight at a level the pediatrician thought should be appropriate. Just a thin kid, nothing else wrong, stomach's fine, everything's fine. They scoped him up and down, they did blood work, and they determined that he had Crohn's disease and celiac sprue, both. Now, mind you, totally asymptomatic. They put him on drug therapy 8 years ago, and ever since they put him on drug therapy, he's been unwell. Went from being asymptomatic to not feeling good, and correlating that with the onset of drug therapy for a disease state that had no symptom at the time. Not suggesting that all these diseases should be ignored, they shouldn't be, but the medical momentum, the momentum of the medical system sometimes overwhelms patients with a sense of urgency and interventions that can cause harm. Now we need to talk to extending logic and extending science, infections. Study recently showed that patients that go to urgent cares, 42% of them receive antibiotics in a manner that is considered to be inappropriate. That means you didn't need them. We know that what we used to say in medical school, a sore throat goes away in a week with antibiotics and 7 days without them, that most of these illnesses are viral in nature and they do resolve spontaneously. What to do? You don't just want to sit around and suffer. Well, 2 studies looking at high-dose vitamin C showed a decrease in the duration of illness when it was administered to patients with viral infections and upper respiratory infective symptoms. 3 studies showed it preventing pneumonia. 148 animal studies showed an alleviation or prevention of infections by bacteria, viruses, and protozoa. The evidence is mounting that vitamin C may have significant benefit in these settings. And most importantly, folks, there's no risk. You take an antibiotic, bad things happen. If you don't absolutely need it, it'll ruin your gut bacteria, the microbiota we talk about all the time. It can take 6 months to recover from 1 cycle of antibiotics. Never mind allergies. Never mind the diarrhea, the side effects that occur, the superbugs that can occur, Clostridium difficile and other complications. So how do you manage this? When a doctor, particularly at an urgent care center, and these are good docs, they're just time pressured and they need to do something for the patient, right? Everybody gets a Z-Pack. It's your door prize. Simply say this, doctor, if I don't take the antibiotic, will I die? And if the answer is no, then simply say, my philosophy, doctor, is to delay antibiotics unless they're absolutely critically needed. I just want to know if this is one of those cases. Folks, if you prime the pump that way and you orient the doctor toward your way of thinking, the doctor will embrace that in most cases and validate that. There's a pressure to prescribe on the part of physicians.
I think they'd be thrilled if I had a patient say that.
Yes,
right?
Because there's an unspoken expectation on the part of the doctor that the patient, want a prescription, that's why you came. And if you don't get one, you'll be disappointed. So they don't want to disappoint. They want you to be happy. They want you to come back to the next time. So if we know as a doctor that the infection is going to last 7 days regardless, 7 to 10 days, and you've had it for 3 days and I give you a prescription, I'm going to get credit for the cure, even though it was coincidental. So that's why we exist. One of the reasons we exist in the space of an upper. Now they can get drips like that without seeing the doc, right?
Oh, they can.
It's like an over the counter.
Yeah.
So you can come into East Bay with
Yep.
Dr. Michael Souza, or you can come into West Bay if you're otherwise healthy. We do have a questionnaire that needs to be answered. And if you're otherwise healthy, you can walk in, get an IV drip for that upper respiratory infection,
Absolutely.
and not have to consider the antibiotics in that setting.
Yeah. Highest dose vitamin C.
That's pretty awesome.
Mhm.
Well, when we come back, we need to talk about the New England Journal study on breast cancer. I think that's super important. And there's a drug that has recently been recalled because they found carcinogens mixed in it. It's a blood pressure drug. and we want to inform you about that. We will be right back. This is Dr. Pederuti at Intellectual Medicine with Shannon.
2 questions.
Yeah.
Danielle writes, I treat with antibiotics for late stage Lyme infection.
Right.
I do take probiotics, and this therapy has greatly helped me get better so far. Can I add high dose IV vitamin C to this for extra protection?
The short answer is yes. High dose vitamin C is toxic to the spirochetes. Long-term antibiotics have had benefit for some patients. One of the difficulties with that becomes the chronicity of the antibiotics themselves, and how do you transition from persistent antibiotics to an alternative approach. We believe in many cases the Lyme disease can create colonies of spirochetes that go into remission and that hide in the body, and that periodically they can reemerge. So months or even years later, you can, without being re-exposed, we believe, based upon what we've read, our literature, and the observation of clinical cases, that patients can have sort of a reinfestation of the spirochete in some cases, which is why we like high-dose vitamin C, because it doesn't ruin the bacteria balance of the gut, because it doesn't create resistance, because it is so safe to use that this can often help patients. And we've had some success getting patients off persistent antibiotic, or if not getting them off of it, complementing it with high-dose vitamin C. So, hey, Lyme disease and chronic Lyme disease is an absolute difficult thing to treat, poorly understood, and it's another area that begs for innovation. So the doctors who are out there thoughtfully applying unique pathways of care, such as extended antibiotics, I applaud their general effort and the direction they're moving in. There's just simply not one pathway to get well. Sometimes Lyme disease can ruin the brain chemistry and the hormone balance, and that effect can linger for months and even years. And unless it's repaired, you just don't get full recovery. The analogy I use is to a kitchen fire, yes? The burn happens, the kitchen's ruined, you put the fire out, but the kitchen's still a mess. It needs to be rebuilt. Lyme disease can be similar. The spirochete does the fire, you get it treated, the spirochete's dead, but you're still suffering the consequences of what occurred. And that's where the rebuild cycle comes in. In our experience, that rebuild cycle can also sometimes be assisted with bioidentical hormonal support and IV therapies. And it can take months, in some cases years. Yeah, there is hope though, so keep moving forward. It's tough. Chronic Lyme, and I'll tell you, it's another great example of innovative doctors being punished. You wonder why your doctor doesn't want to touch you when you tell them you have chronic Lyme. It's because other doctors who have been reprimanded because they're not following the standard of care. What is the standard of care for chronic Lyme? I'll tell you what it is. Ignore the symptom and send the patient to the psychiatrist. That ain't right.
And the help of an expert. You'll find both on RILiving.com, where national real estate sites get their information. But as the official website of RI Realtors, RI Living has it first, and RI Living has it right. No other site updates as often. Plus, RI Living can help you find a realtor. So find your next home and the expert to help you make it yours on RILiving.com, the source for all things real estate. Hi, this is Steve from Warren.
Did we talk about the animal study and the stress changing their brain? I'll put that in next week. We did the antibiotics and the urgent care, vitamin C, the study from nutrients. Okay. Okay.
Now back to Intellectual Medicine with Dr. Pederuti. Call in now at 438-WPRO or 1-800-321-WPRO.
So there we are. Hello, everybody. Welcome back. So there we are. We're talking about, Shannon, innovation. And we're talking about proof. And we're talking about progress in medicine. And we just took a call off air from a patient who's suffering with chronic Lyme disease. This is another black hole demanding innovation. If you've suffered Lyme disease and you still have symptoms of it, you know what I'm talking about. You know what's interesting to me is when you present to most orthodox physicians, and you say to them, "Doctor, I think I may be suffering with chronic Lyme disease," they flip into defensive mode, right? They in many cases they start to repel the notion. There's a reason for that, because my courageous colleagues who are innovatively pursuing avenues of care for patients with chronic Lyme, their reward for that is punishment. In most cases, they risk censure, they risk reprimand because they're not following the standard of care that for chronic Lyme effectively does not exist. There's a standard treatment that is widely embraced even by intellectual medicine doctors like me. If you have acute Lyme disease, as evidenced by blood work, symptoms, or the classic rash, the 21-day course of doxycycline is broadly endorsed as having essential role in treatment. However, 20% of people approximately will not be cured by that. And some people will present with symptoms of chronic Lyme that can linger for years, right? Fatigue, muscle ache, brain fog. The doctors, by and large, many doctors deny its existence, or they will acknowledge that, quote, something's going on, end quote, but not offer a path forward. Just because a proven path forward does not exist that is universally embraced does not mean, ladies and gentlemen, that you have to suffer without the pursuit of a remedy. That's called intellectual medicine. That's called innovative medicine. Call it off-label treatments. It requires a thoughtful application of knowledge. So let's look at cancer again, because there are parallels here. Another black hole. New England Journal of Medicine, 2017. The recurrence rate, a distant recurrence. And what that means, distance recurrence, is 10, 15, 20 years after your cancer was treated, it comes back, usually like a house on fire. In this case, they looked at breast cancer, and they found that women who had a T1 breast cancer, now that is a cancer, lymph nodes are negative, the size of the tumor, less than 2 centimeters, small by most standards, surgically removed, treated by standard of care, put on hormone suppressive therapy. The standard is typically 5 years. They'll put them on hormone suppressive therapy if it's indicated. Unfortunately, 13% recurrence rate, distant metastases. 13%. That's high. If you could buy a lottery ticket that had a 1 in 10 chance of hitting, you'd think those odds quite good. This is just the opposite. The distant metastatic rate goes up as high as 40% for other forms of cancer. There is a desperate need for innovation in this population. You cannot stand those hormone suppressive therapies. They will ruin your body. They're going to shrink your bone. They're going to make you feel awful. There's got to be a better way forward. And we can't wait for the ponderous process of university-based studies to get us there. When you have a 20-year recurrence rate, you're talking about a 20-year study. At Intellectual Medicine, we have theorized that there's a possibility. I have to be careful with my language here, right? Because I know you're sitting out there, ooh, get your pen ready, my critics, right? Write it down. We theorize there's a possibility based upon its mechanism of action that vitamin C, dosed on a regular basis, high dose intravenous vitamin C, may have an impact on that recurrence rate. We advocate for its use because of its safety. It's very inexpensive, and we're going to be endeavoring to track these outcomes over years. This is innovative medicine. This is application of a thoughtful approach to a black hole problem that has nothing to offer it currently. We're in the spirit of other doctors like Rebecca Glazer. She's a physician who's an expert in testosterone therapy in women. You know what she found, Shannon? Now, we know testosterone is phenomenally beneficial to women, particularly in their 30s, 40s, 50s, and beyond, because when they start to suffer the decrease in testosterone, they get weak, tired, brain fog, lost muscle, lax skin, lost libido. Can I go on? There are androgen receptors in every cell in your body. especially in breast tissue. And it turns out that it has an anti-proliferative effect, and that in Dr. Glasser's work, she has noted a decrease in breast cancer rate in women on testosterone. She's had case studies where she took breast cancer tumors and surrounded the tumor with testosterone pellets and saw the tumor shrink. Now, it's not proof, but it's evidence of value. IV vitamin C. We don't have proof that if you go on a regular regimen of intravenous vitamin C, it's not FDA approved, by the way, to treat any cancer. You got to be out there. It's off-label use. We don't have proof that if you do this for 10 years, the cancer will be more likely to be in remission. We know it to be safe. We know it has a biological, plausibly effective pathway. And we want to make this available to those who choose it. Do your homework like you do. Go to the internet and read. Have your healthy skepticism. Take my words and challenge them yourself. It's a beautiful age now. You can do that, right? You can research, and you don't have to rely upon one oracle of evidence, be it us or orthodox medicine. There's a desperate need for innovation in the cancer care treatment arena. The oncologists are brilliant, thoughtful, and heartfelt clinicians who are overwhelmed with their own silo of care that has to do with chemotherapy and all of its permutations. When it comes to supportive elements beyond that, it requires cooperative care and another silo of knowledge. That's what we pursue at Intellectual Medicine. That's what Dr. Michael Souza, Shannon, and I, and others to come. We are pushing the boundaries of delivery of intellectual medicine. It's our goal to make this available to all those who seek or want it. So, anything else I could say about that? I feel strongly that this needs help and innovation. And Shannon, you do too. I know you've had to deal with this personally.
Mm-hmm.
You know?
I do my high dose vitamin C every month. Cancer twice, what's the rate of that coming back? Pretty high.
You got melanoma twice. It is a scary cancer that hides and then mushrooms out, it seems like overnight. So we need help with these pathways. But about that recall, valsartan, blood pressure drug, right? They found NDMA, which is a carcinogenic substance, in the pill. How did it get there?
For like 4 years, right?
Nitrosodimethylamine for up to 4 years. Now, folks, this is not every valsartan drug, so don't throw your pill away immediately, but there is a recall. Talk to your pharmacist and find out if your valsartan, your blood pressure drug, is involved in that recall. These are the pills that were manufactured, guess where? China. I don't know. What are they doing over there? Putting carcinogens. Maybe it's part of a plot to eradicate America.
That's FDA approved, though, right?
It's like, the FDA does not want you to take carcinogens. That's like
it was approved.
It's approved. Well, listen, folks. Once again, you've squandered an hour with us. That's a beautiful thing. We will be back next week. Dr. Pederuti and Shannon at Intellectual Medicine, wishing you 120 youthful years. Hey guys, thanks for tuning in and thanks for your thoughtful questions. We hope we've been able to be of some enlightenment to you. We'll have you back again next week. You can Facebook us and you can find us like you have and relay those questions, and we'll try to respond throughout the course of the week. Thanks a lot. Yes.
And we got to end this, but we will answer your questions after we get back to the office.
Okay, yeah, we do need to wrap up. The questions will be answered. Thanks, gang. And thank you, folks. Should I end stream here, Shan? All right. See you next week.